we can't tell from this data exactly why people were taking it. All we can say from this data is, right, if you think about it, we have a delivery, we're pretty confident the delivery happened. And then we carved out these broad windows of time, like, essentially a year window around the delivery time. And then we're counting, like, okay, do we got GLP-1 like medications popping up through the pharmacy records? And the answer is yes. We're very confident like that number is increasing. Now, to me, it's like, does that mean people are feeling a ton of it? It's like multiple months of it? Why? I'm not sure. And I think Jeannie alluded to that too, right? Like we're not sure like the as to exactly what is happening, but it is rising. Something is happening there, which is probably the next step for us to get into. I think from my standpoint as a methodologist looking at this data, my thinking is, this is at least enough to make a clinician think to themselves, okay, this should probably be on my radar and be on the differential, something to keep my eyes peeled for. It's like no longer a rare thing.
And we have some comorbidity data in the year prior to delivery, right? So we know that the clinical indications for GLP-1 use is for weight loss, for obesity, and for diabetes management. We do have that data. There's a fair amount of that cohort who have an obesity diagnosis prior to pregnancy, a smaller number who have type 2 diabetes diagnosis as well. Not 100% though, in
Mm-hmm.
either bucket. And so, do those diagnoses show up postpartum in many people? Absolutely, for both. And so these could be new diagnoses that happen postpartum that give them a medical indication to start these medications and prior as well. But we don't have that indication quite clearly spelled out, postpartum or pre-delivery.
Yeah, I think that's really, really important. And one of the key things we need to look into is the next step. Because as I was saying, a lot of the databases that allow you to get into more granular detail, trying to understand, you know, race, ethnicity, insurance, geography, state level factors, like what states might mandate in terms of coverage. Those databases are often the ones that have lag times or may not cover as much of a broad swath of the US. And so, oftentimes, when we're thinking about picking databases to do this work, we might want to start with like a broader one to see like what's happening across the US among the largest swath of people, and then maybe pick a database that allows you to like get into mechanisms. But those are also the ones that are less ideal for time sensitive public health monitoring. So I think that's super important. And that's definitely something many of us and our colleagues are also thinking about.
I think that is a billion-dollar question that you asked. And, given the sort of pretty clear recommendations that are currently out there for obstetricians in prescribing GLP-1s in pregnancy, I think our party line is going to be that statement, which is there's not enough information about these medications during pregnancy. The current FDA recommendations are to stop 1 to 2 months prior to conception. That being said, we have some data to suggest that if you do have inadvertent first trimester exposure to these medications, we're not really seeing an increase in things like congenital malformations or teratogenicity or sort of harm to the pregnancy. We do recommend that folks stop because we, again, don't have a safety data out there to support its use, but we don't really see a harm signal either from the data that does exist. That being said, for something that overlaps with pregnancy this much, I think for obstetricians out there, it's really important to make sure we are able to, one, evoke this data, this history from our patients, because it's going to be incredibly common. Patients may feel ashamed or embarrassed that they're on medications that they potentially think that they shouldn't be. I think it's really important to get this information from patients so you can have the appropriate counseling and overall reassurance that we don't see a harm signal, and then have a discussion about what to do with the medication during the pregnancy and potentially what time to start. The other piece of missing information is lactation data. We really don't know what the sort of breast milk expression impact on lactation. We don't have that data available. And right now, I believe the guidance is for shared decision making about these medications during breastfeeding. All of this really requires a lot more information and a lot more data. And I think it's especially important because, again, those medical indications right now for GLP-1 use, which is obesity and diabetes, is incredibly common for pregnant individuals. But there's also going to be additional indications coming up soon. This medication is being explored in a lot of medical conditions, including things like substance use disorders, that the harm of, if it's truly effective for other indications, the harm of stopping them, could be higher than not stopping them. So that's a really kind of nuanced discussion, I think, as more data comes out and potentially more indications for use come from this. The other piece of this, I think, is actually important for non-obstetricians. We kind of try to think about, pregnant women and pregnant people and their medications solely in the circle of OB-GYNs, but OB-GYNs are not the ones prescribing GLP-1s in the vast majority of cases. And I think that's really important. And we see that a lot from our, patients who have, psychiatric comorbidities who are on medications, and kind of a corollary to GLP-1s, folks who undergo bariatric surgery. There is, as we get healthier, and especially with weight loss, there is a huge increase in fertility for patients. And if you are not on top of contraception for someone who is experiencing, rapid weight loss, even if they were anovulatory or had, a weight-based infertility prior to the weight loss, they're at very high risk of getting pregnant, inadvertently if that's not in their plans during this time. And so, we've seen this already with our bariatric surgeons. Like, it's very strongly encouraged and recommended for contraception 1 to 2 years after surgery. This should be a very important discussion for anybody who's prescribing GLP-1s in, reproductive capable individuals.
I want to give some credit to two trainees who played a major role in doing this. Sometimes, we faculty members are stretched really thin, and we sometimes need a bit of an extra push from young, really promising people to be like, oh, I'm so curious about this. Like, have you thought about studying this? And then it kind of gets us into this frenzy of like coming up with the study. And there were two trainees, Chloe Lessard, who's an OB-GYN resident at Kaiser Permanente in Oakland, and then Caroline Carey, who's a medical student at WashU. They were phenomenal. And they played a big role in really nudging us to be like, oh, have you thought about like using these methods that and like Jeannie's expertise to really come together and do this work? So I want to give them a shout out.